are both massively important in head injury patients. The damaged brain is very susceptible to hypoxia and very susceptible to hypoperfusion. So we've got to make sure that the blood pressure is high enough to get the blood into the brain, and we've got to make sure that that blood is well oxygenated. So if the patients have got low blood pressure, make sure we start giving them some fluid resuscitation. Probably a plasma expander, some sort of colloid in the first instance. And give them oxygen as well. Remember, lack of oxygen will not only stop the machinery from working, it will wreck the machinery. And this is certainly the case with the brain. If the brain is hypoperfused for a period of time during the acute admission phase, or it's hypoxic for a period of time during the acute admission phase, that significantly worsens the patient's prognosis. Very important to get those right very early on in management. And then when that's stabilised, most A&E departments will go on and do what we call a secondary survey, looking at the chest, the abdomen, the pelvis, to see if there's any other significant, potentially life-threatening injuries, which in fact may take priority over the head injury. And any severely traumatised patient in an A&E department will normally have x-rays of the neck to check the C-spine, of the chest and of the pelvis, because all of these can be associated with significant life-threatening injuries. So what is the kind of priority where head injuries are going to come into? Well, airway, breathing and circulation take priority, but then so do injuries that cause significant hemorrhage, because the patient can bleed to death more quickly than they're likely to die from the head injury. That's why the pelvis is so important. A fractured pelvis can lose 2 litres of blood really quite quickly, and that can be an immediate, life-threatening, hypovolemic sort of situation. It's the same with the chest. If there's chest injuries, then they can interfere with oxygenation. And again, we're talking about an immediate, life-threatening situation. And as the patient's examined, it's very important that they are log-rolled. That means that the whole patient is turned as one. So there needs to be a team of people moving the patient, and the person who has the patient's head is in charge of the whole procedure. And they'll normally count the roll. So you'll say ready on 3 or move on 3, 1, 2, 3, then everyone will move the patient at the same time to keep the vertebrae and the limbs and the head all aligned. Checking that the trachea is central is quick and easy. What might it mean if the trachea was deviated onto one side? Well, this can indicate the development of a tension pneumothorax, pushing the heart and the trachea across onto the opposite side of the chest. And that would require immediate attention. It's a life-threatening injury. Rib fractures might interfere with normal ventilation, and again, they may need to be addressed. Checking air entry on both sides to make sure that the air is getting into the lungs. Again, quick and simple, just a matter of listening to the air entry, but important. Because breathing problems are actually quite common in patients with head injuries. So keep the airway patent, give oxygen, and use suction to keep the airway clear if necessary. Now, in patients with more severe head injuries, their level of consciousness will drop. And we measure consciousness using the Glasgow Coma Scale, 15 being normal. And the rule of thumb is that if the Glasgow Coma Scale is 8 or less, then it's time to intubate that patient. So the rhyme is less than 8, intubate. And of course, when the patient is intubated, they'll be sedated, their muscles can be relaxed, and we can control the airway and the breathing very well. But whether the patient is intubated or not, we should be constantly monitoring oxygen saturations, looking for high levels, at least 95% and preferably higher. So the higher the better really. Make sure the blood is fully oxygenated. preventing hypoxic secondary brain injury. Always remember that the injured brain is way more sensitive to oxygen lack than a healthy brain is. So these patients need to be well oxygenated, monitoring the saturations. And as well as that, if the facility is available readily, it's worth doing arterial blood gases. Firstly, to make sure the level of oxygenation is adequate, but also if the level of carbon dioxide is building up in the blood, this can also increase the severity of the head injury by raising the intracranial pressure. So high levels of carbon dioxide also need to be avoided. So we want good levels of oxygenation and no raised levels of carbon dioxide. We do not want a hypercarbia, or hypercapnia means the same thing. Hypercarbia is probably the more modern term. So this means, if at all possible, we want anaesthetic help. An experienced anaesthetist can significantly improve the prognosis of a patient with head injuries. And patients with head injuries can often have other damages as well. Scalp and facial wounds, for example, can bleed an awful lot. There can be incised wounds caused by sharp objects such as glass from a windscreen, or there can be lacerations caused by blunt objects. But faces and scalps can bleed quite a lot, so you might need to arrest hemorrhage to external injuries. So we're now talking about traumatic brain injury that has occurred as a result of trauma. Now these are very common, but fortunately most of them are mild. So of those admitted to A&E departments, probably a good 75% are going to be a fairly mild level of trauma. But some are moderate, and as we see with the moderate, the Glasgow Coma scales are going to be 12 to 9, between 12 and 9, as opposed to just below normal levels of Glasgow Coma scale with the mild head injuries at between 15 and 13. But if the Glasgow Coma scale is 8 or less, this would be classified as a severe head injury, severe traumatic brain injury. And everyone would agree, I think, that a severe injury, the patient is unconscious and unable to follow commands. So severe injuries, unconscious patient, unable to follow commands, low Glasgow Coma scale, probably 8 or less. To understand head injuries properly, we need to know a little bit about intracranial pressure, the pressure within the cranial cavity. And this goes back to the early years, actually, of the 1800s, even before 1850, with the Monro-Kelly hypothesis, or the Monro-Kelly doctrine, formulated by Monro and Kelly way back then. And this is based on the idea that the cranial bones form the cranial cavity, and that inside there is a closed vault. It's completely closed inside here. And this is fairly obvious when you think about it, because if you feel your head, there's no gaps. It's a closed cavity. The cranial cavity is surrounded by the cranial bones. And of course, I know there's gaps on the bottom, but in life these are filled with connective tissue, neurological tissue, and blood vessels. So the cranial cavity, which we can see if we open this skull, the cranial cavity is completely surrounded. It is a closed vault. And that's important because it means that no expansion is possible. It can't expand. So like if you get an injury to your abdomen, your tummy can start sticking out, but this can't because it's bone and it won't expand. Now the intracranial cavity is around about, in an average adult, about 1450 mils, something like that. And Monro-Kelly rounded these figures off. They said that the brain occupies about 80% of intracranial volume, that blood occupies about 10% of intracranial volume, and that the cerebrospinal fluid occupies about 10%. So it's 80, 10, 10. More accurate modern figures might be that the brain is about 1300 mils, that the blood is about 110 mils of intracranial volume, And the cerebrospinal fluid is a bit less at 65 mils. But, you know, the Monroe